Bismillah ar-Rahman ar-Rahim. Hello, everyone. You are most welcome again in Ziada Academy for continuous ophthalmic education regarding the anterior segment surgery. Today, I will show a mission impossible in cataract surgery when you have a cataract with octopus thick membrane, octopus-like thick membrane. This membrane was retrocorneal and anterior capsular at the same time. So it was very difficult mission, so I called it Mission Impossible. For this mission to be impossible, actually I had a lot of difficulties in such situation. The young age, the very angry inflammation. So the clinical data for this case, this boy was 16 years old from rural area, so he was swimming all the time in the River Nile, where there is a lot of parasitic infections, with past history of long-standing chronic anterior granulomatous uveitis. He presented with granuloma in the anterior chamber and with different episodes of treatments. The granulomatous inflammation subsided, leaving back this huge and this thick membrane. As you see in this picture, its retrocorneal membrane looks as if it's one. It's apart from the cornea itself. The visual acuity was hardly hand motion. The intraocular pressure was 18 deci. The fundus not seen. So I'm going now to do cataract surgery after 3 months of medical treatment, including steroid. So I have this retrocorneal membrane with thick adhesions to iris and lens at the same time. So I'm now the 6 side ports, 3 on each side, 1 for the instruments and another 2 for the iris hooks to stretch this pupil and to get a window and approach to what's posterior. I couldn't see because it was not dilated. Actually, the Medriatics showed no response at all in the clinic. So I'm going now to stretch the pupil with just these 3 iris hooks. So I found this island, this brown, darker brown island inside this sea. Finally, I got a radar flex and I could see this superior part of the lens. I found it clear. I'm gonna to inject the viscoelastic and then trying to check for the separation of this membrane, and fortunately I could separate the membrane from one of its sides away from the back of cornea. So it was a very happy moment when I could separate it. I was worried about the separation to be with the stripping of the descending membrane together, but thanking Allah, I could separate it, leaving the endothelium and descending membrane in its site. I'm trying to find another edge to complete separation of this. I'm going below this membrane, trying to separate it from the anterior capsule, but actually it was very thick and very adherent, and these fine instruments didn't do any job with this huge and thick membrane. I'm trying again to separate it together with injection of the viscoelastic to protect the endothelium. I'm trying again. So I'm trying to stretch it and to peel it from the back of cornea, then to peel it again from the anterior surface of the iris. but every other trial, I was injecting a lot of visco material to help getting me a space, and at the same time protect it protects the cornea from this manipulation. Now I'm sure that there is no points of adhesion between the membrane and the back of cornea. It's totally separated from the back of cornea, but remains attached to the anterior surface of iris. So I'm trying now by this big scissor, like a shark going inside the antechamber to eat this octopus, but this shark didn't do any job with it. I think I need the white whale or the blue whale to do this job. But I'm trying to think and to store my brain how to get. Until I find a way, I started to do anterior capsulotomy to remove this cataract, to get a deeper space and easier manipulation inside the antechamber to deal with this thick membrane. By irrigation aspiration, I aspirated all the cataract and lens matter. I was worried about stretching of the anterior capsule because really the visualization was so difficult and so hazy. But I'm trying all the time to preserve the bag to put the IL. I injected the foldable IL underwater as I used to do in all my cases. Under any situation, I can implant it underwater, except in the case of the vitreous prolapse. But fortunately, I didn't get any vitreous prolapse. The bag was intact and the zonules were completely normal in all around. Finally, I got this microforceps, the microrhexis. It was very helpful to catch the membrane and trying to peel it from the anterior iris. The anterior iris, but at the same time, keep in your mind not to be aggressive one. You can peel the membrane, but at the same time you may get iridodialysis, and I think you will be a big loser if you had it. So I'm trying to be balanced to catch the membrane without getting iridodialysis. Yeah, the main part of the membrane was brought out. Yeah, so I feel more comfortable. And I can leave the remnants of this membrane on the anterior iris without any problem, but I'm trying to be sure. I'm trying to sweep around to be sure that there is no adherence. But actually, and finally, you will find that this iris, this pupil becomes distorted. It's not regular. So I will try to do a cosmetic step to get a more lovely and more beautiful pupil by iridoplasty using the 4-throw 1-pass stitch. Yeah, I'm going now to put the inferior suture, grasping the both sides together, then pass by the straight needle, using the straight needle with thin proline suture material, then from the temporal to the nasal side. Then I will keep both sides of thread on both as such on both sides, then I will grasp the suture from the side of entry to take just part of it to make a circle, which is the one pass. Then on the left side or the exit side, you will cut it and then enter with this free end and count for 4 times. Is it third? 3 times, yeah. I'm trying to go to 4th, and be sure you can add 1 to be 5th. It's very important to make them 4 throughs. Finally, both ends are stretched together to form a very good and tight knot inside. Then cut the free ends. The same for the superior part of the pupil. To make it very, very close to the normal one, you will do the same thing for the superior as was done in the inferior suture, the same technique. Then look at the anterior chamber and the pupil. It's almost normal one, and finally I close the all side pores with a stromal hydration and inject the lovely air bubble. And I have ended my operation with injection of subconjunctival triamcinolone in the inferior fornix. One day after, there was subtotal hyphema, so the unaided visual acuity was hand motion was much better than the preoperative vision. And after 1 week, surprisingly, the hyphema resolved, and the patient could see 618. Yeah, it was very surprising for all of us. This is the picture preoperatively, and this is the picture postoperatively caught by my mobile camera. So the resolution is not that good, but anterior chamber is well. The cornea is clear, and the patient could see again. So the mission impossible, but finally it was done. Thank you very much. Thank you for watching, and I hope it a beneficial video for all of you, and see you in the next video. Bye-bye.